Hello guys, am I audible?
Yes. Hi, Doc. Yes, you are. So I had informed the rest that we give other participants ample time to join. So we were to start at 4:05. So I'm seeing we are at 37. We can start. I think the rest will just find us on the way. For those who've just come in, my name is Lucy Machotra. I'm a pharmacist by training and a technical programs assistant here at African Pharmaceutical Network. So today, before we even get to the session itself, I'd want you to let us know where you're joining us from and what your background is, as I share the housekeeping rules that we'll use during the entire session today. So I've just, there's a poll that will appear on your end, asking you to tell us where from Africa you're joining from, and another will follow on what your professional background is. All right, I'm guessing it's come. So as for the housekeeping rules today, one, I'd like to request everyone to just keep their audios off. You can turn on your video, that's all right, but you're trying to minimize background noise and interference during the session. So if you could kindly keep them muted. And for the questions, in case there are any questions that come up during the webinar, then please use the chat box to be able to submit them, and then the speaker will be able to address the same at the end of the session. However, the session itself is structured in a way that the Q&A session is supposed to come at the last 20 minutes to be for the Q&A session. So I'm about to launch another poll on your professional background. So kindly also submit that. All right, so today we will be talking about health economics and outcomes research in health products procurement in Kenya. And this conversation is actually following a previous conversation that we had sometime last week on health technologies assessment in health products procurement in Kenya as well. And I will actually share the recording to that previous session in the chat during the meeting, because I've gotten some requests on that as well. So today's topic is inspired by the growing interest in the field, because especially in Africa, where resources are constrained, governments are grappling with how they can provide the best possible healthcare outcomes with affordable cost. And data is becoming a very big thing when making healthcare decisions, and the complexity of it. The complexity of this healthcare decision making has been intensified with things like increasing innovations in medical products, growing burden for diseases, the increase in access to, or rather advocacy for access to healthcare, universal health coverage, and bringing the healthcare to within a 5-mile radius. So it's a very crucial topic for us to have, and healthcare issues, it helps us generate health economics and outcomes research, help us generate relevant evidence to inform and guide relevant healthcare decisions and investment. So with that, I think I'm going to welcome my colleague Juliet to give us a brief overview of what we do as an organization, and then the speaker will take the session. So Juliet, karibu sana.
Thank you, Lucy, for that introduction. Good evening, good afternoon, good morning, everyone, from wherever you're joining us. My name is Juliet Ouma. I'm the Programs Assistant at APN, and I'm going to quickly take us through the overview of APN, the work we do, and the reason as to why we exist as an organization. Let me share my screen. I hope you can see my screen.
Yes, we
Yes, we
can.
can.
Thank you. So African Pharmaceutical Network was established in 2020 during the COVID-19 pandemic out of the desire to address the challenges faced in the pharmaceutical industry and in the healthcare system of Africa. Considering the unrest caused by the pandemic all over the world, its impact in different regions, the limitations of Africa's pharmaceutical system were exposed as of that time. Such limitations include weak regulatory systems and weak healthcare systems. Therefore, African Pharmaceutical Network was established as a network that brings together pharmaceutical professionals, stakeholders, organizations working in the African pharmaceutical sector for the purpose of knowledge sharing, policy shaping, and innovation nurturing partnerships towards a robust pharmaceutical sector. Our mission and our vision as an organization is to ensure reliable access to safe, efficacious, affordable quality medicines and pharmaceutical services for the African people. As I had said, the background towards the establishment of our organization was anchored through limited local manufacturing capacity in Africa. We know that Africa depends on importations when it comes to pharmaceutical products. This is 70 to 80%. But right now we are about to change that narrative, especially with the launching of AVMA project in Paris yesterday. This is the African Vaccines Manufacturing Accelerator, which is going to boost manufacturing of vaccines in Africa. So we also had the issue of segregated continental pharmaceutical industry operations, ranging from regulatory processes, pharmaceutical supply chain, and other pharmaceutical care. This is a case where we find that stakeholders within the pharmaceutical industry are working in silos. Therefore, we come together and we provide a platform and we give the agenda that we can come together, work together, so that we can have a pharmaceutical industry that is robust and it is going to promote the quality healthcare of the African people. There was also a lack of local platform to drive industry-led continental agenda. Therefore, the network was formed as a platform for stakeholders, professionals, and organizations to come together to drive industry-led conversations. Our aim: we foster continental knowledge sharing and workforce development within the pharmaceutical industry. We promote best practices and stimulate innovative models of service delivery in the pharmaceutical industry. We also champion for responsive, market-driven policies and regulatory frameworks in the African pharmaceutical industry. We also stimulate investments in the African pharmaceutical industry. So what are our key pillars? So our priorities are pharmaceutical workforce development, a business ecosystem support, and policy shaping. And for this kind of industry forum that we are having today is anchored on the first pillar, pharmaceutical workforce development, where we ensure that Africa as a continent has a pharmaceutical system that is effective. And how is it going to be effective? When we have a workforce that is well-trained, skilled, and qualified. And how do we do this? Through industry discussion forums, such as the webinar that we are having right now. This is an industry discussion forum where we are coming together to share knowledge, and we hope that at the end of this session, you will be enlightened, and that which you are going to get from this place, you are going to use it to drive change in your respective countries, in your regions, for the betterment of your people. We also do this through training and experiential learning opportunities. The African Pharmaceutical Network has an Pharmacy Academy. The Pharmacy Academy has different training programs through which we train pharmaceutical professionals on different areas, such as the regulatory affairs training, of which many of us have already heard about this course. Right now, we are in our second cohort in this year. We have the pharmaceutical supply chain, which is rolling out in the next few weeks. And then we also have the pharmacovigilance training. We also do this through policy advocacy and environment shaping. Through our policy advocacy right now, as African Pharmaceutical Network, we are focusing on the AMA ratification treaty, and we hope that you will also take up roles in participating in such initiatives. We also do market intelligence and technical support to stakeholders. Through the intelligence that we gather, we share this with our members, the members of our networks, and any other person who is going to reach out to us to collaborate with us and seeking support from African Pharmaceutical Network. So, which is the team behind the vision that we have as APN? We have an advisory board, a secretariat, and a leadership team. In our advisory board, we have Dr. McDonald Nose. He works with Takeda, based in the US. We have Kirti Nasai. She's a technical expert working with Chemonics International. She's based in South Africa. We also have John Paul Omolo, who is actually the board chairperson. He works with PATH. In the secretariat, we have Dr. Lucy Machocho. We've just met her. And then we have me. In the leadership team, we are privileged to be led by Dr. Odhiambo David, who is the curator of this organization. We have Dr. Kelvin Odongo, the director of operations, Dr. Esther, who is in charge of research and knowledge management, Dr. Denish Kineni, our lead PV trainer, and Dr. Anushri Patel, who is the lead trainer in regulatory affairs. Our partners, we have FIP, IFPMA, H3D Foundation, Bloom Public Health in Nigeria, Empower, School of Health, African Pharmaceutical Forum, Reculture, and the SPAC. Our geographical footprint as at the moment is in 16 countries. And the countries in blue, those are the countries where we have been able to have presence. And we hope to keep gaining ground in the different countries that are remaining in Africa and also towards the other countries that are outside Africa. So when it comes to our offering, pharmaceutical workforce development, which I had spoken about, but I won't focus on that right now. These are the courses that we have at the Pharmacy Academy, the Regulatory Affairs Training, Pharmaceutical Supply Chain Management, and the Pharmacovigilance course. And moving forward, it is my desire that we would partner with us. If you have a desire to train in regulatory affairs, in supply chain management, pharmacovigilance, you may take up your slot with us and train with us for these courses. So what next for you? What next? You may become a member of APN. You can partner with us on the projects that we have, or you can learn with us. With this much said, I would like to hand over this session back to Lucy, and I hope that we are going to have a wonderful session this afternoon. Thank you.
Thank you for that elaborate overview of what we do, Juliet. So I will move on to introducing our speaker, and then we can now kick off. Also, just to let you know that this session will be recorded and will be shared to you at the end. Let me know when you can see my screen. I'm sharing it. Dr.
Yes.
All right, thank you. Dr. Ahmed is a seasoned medical professional with over a decade of experience in public health, medical affairs, and health economics. He earned his bachelor's degree in medicine from Ankara University School of Medicine in Turkey and pursued a master's in health economics and policy at the University of Nairobi. Throughout his career, he has amassed extensive knowledge and experience in emergency medicine, monitoring and evaluation, quality systems auditing, financial administration, and oversight. He currently serves as the medical science liaison at Novartis, Kenya, And in this role, he has positively impacted healthcare across the Eastern region through strong relationship with various stakeholders, including healthcare professionals, policymakers, payers, and patient advocacy groups. He has also designed and executed pharmaceutical engagement sessions between private payers and KMA, that's the Kenya Medical Association, participating in reviewing of four new healthcare bills in Kenya. His leadership and membership affiliation. So he's a dedicated member of the Kenya Medical Association, managed healthcare committee, where he actively contributes to healthcare policy analysis. He's also the chairman of the Kenya Association of Muslim Medical Professionals, Nairobi branch. He's a board member of the Board of Trustees at the KHA Nairobi Hospital Provident Fund Scheme. His dedication to the healthcare field and his leadership roles underscore his commitment to advancing healthcare in Kenya and beyond. So with that, I'd like to give a warm welcome to our speaker. We are happy to have you.
Thank you, Lillian. Please confirm you can hear me.
Yes, we can.
Thank you so much, and thank you so much for APN for inviting me. It's amazing that the first time I'm having a contact with the APN is as a presenter. That shows how late I am to the game. And thank you so much for the introduction. It's always very flattering when someone else is introducing you. And it sounds like they're talking about someone totally different, but thank you so much. So great to be here and a great topic, something that I'm really passionate about when it comes to health economics and health technology assessment. Glad to see a good number of colleagues joining, people that we interact in different sectors who have a bit more experience than me, I guess, in the field. And so looking forward to sharing a bit of what I know about this field and interacting and learning more from our discussions later. So if you allow me, I would want to share my screen, and then you let me know if you are able to see them. Is the screen visible from your side, Lillian?
Yes, it's coming up.
Visible?
Yes, we can see it now.
Is it in full screen? Okay, thank you. So health economics and outcomes research, that's the topic I was given. There was the second part of this topic when it comes to health products procurement in Kenya. And as we continue, you'd see, you'd sense my frustration in trying to combine the two because this is quite a new field. But I'm glad that the discussions are happening, meaning we are getting somewhere, and the importance of this field is now becoming apparent to everyone. I would want to start by a disclaimer that in today's presentation, I'm here in my personal capacity, and anything I present today is not any message from my employer. This would be the outline I would want to undertake as we go through this. I would hope to make these as interactive as possible, and I'm glad that we started with a number of polls. And just to show you how serious I am with that, the first one is there. So please, if you have a phone, just scan the QR code, and let's start with counting. It's an economics class, so we cannot avoid counting. If there is any challenge in accessing the page, please let me know so that and I want to promise you that this is the hardest mathematics we'll do for the day. So don't be worried. Just a moment. Something I need to do here. Sorry. I'll have to reshare this as differently. Are we still back? You're able to see my screens?
Yes, we can.
Okay. So you can see the results. Huh? So I think majority of you have counted 5. A number of you have counted 4. These are 11 responses. If we can get a few more, then we'll move. I think my majority are gravitating towards 5. Okay. So actually the correct number is 6. I will not go back to that slide for counting, but at the end we can check that again. Yeah, but the actually 6 Fs. And I'll show you how that number is. But thank you for indulging me. So if we move now to exactly our topic of the day, health economics and outcomes research. So as I mentioned that this might sound like a new field from our side, but it's not exactly new uh, within the health economic space. And it is a multidisciplinary field that would assess the value of healthcare interventions and policies, aiming to understand the economic impact, clinical effectiveness, and even more important lately is the patient-reported outcomes of these interventions. ISPO would define this as the study of the value of healthcare interventions in terms of their cost effectiveness and patient outcomes. Anytime, of course, you're talking about, you're discussing anything to do with economics, we always go around the concept of scarcity, that our resources are never enough to cover our needs. Meaning at some point, we are forced to make a choice of where do we invest our few resources and be able to maximize benefit. So that combination is what now forms the HEOR. And last week we had a discussion about health technology assessment, and I wanted to put a slide just to show what is the difference between the two. So HEOR aims to provide the evidence on the value of medical treatment, devices, pharmaceuticals, and this informs decision making by the providers. Now, the HEOR primarily would be used by pharmaceutical companies as part of their value dossier, healthcare providers. It's a discussion that payers really would use when you're having a discussion about reimbursement. Now, health technology assessment would use the evidence derived from the HEOR. So HEOR will provide the data that is key within the HTA. And the HTA is a multidisciplinary process, evaluates the social, economic, organizational, and ethical issues of health interventions. So HTA is more compassing. So it would look at so many other things over and above just the economics and outcomes. And this is mainly now when it comes to government, health authorities, policymakers to guide decisions on whether a technology should be funded, should be reimbursed or adopted within a healthcare system. So in summary, you'd notice that these two are quite interrelated. And they both contribute to the evaluation of decision-making process in healthcare. So the HEOR focuses on generating the data, and the HTA uses this data along with so many other information to make some comprehensive assessments about health technologies. And when we talk about here health technologies, it traverses everything. This could be medications, this could be equipment, this could be, building a pediatric center. So it's very encompassing. This is a bit of a pictorial of the same, where we say the health economics focuses on measuring and valuing outcomes of healthcare intervention. So here would look at the cost and a bit of the consequences of the healthcare intervention. Then the outcomes research comprises a set of scientific disciplines that would evaluate now the effect of the healthcare intervention on patients. So the outcome research is more on the patient side. And the HEOR, now health outcome economics and outcomes research, is now the confluence of the two fields that together provide powerful data and insights for healthcare decision makers. So what are the objectives? Why would we do this? Why would you do HEOR? So one is to inform decision making, where we want to make evidence-based decision makers, both at a healthcare provider, be it a policymaker, be it the payers. Using the data we get here, we can improve health outcomes. As we said, patient-reported outcomes are very, very key when it comes to HEOR. Then optimize resource use. Again, we go back to the issue of scarcity. Where do we allocate our money? The allocative efficiency, as we say, where to achieve maximum health benefits within the budget constraints. And of course, policy support. So these are some of the key components of HEOR. Of course, we have the economic evaluation, where we are asking ourselves what makes sense in terms of value for money. Then there's the budget impact analysis. So once we do the cost evaluation, we need to ask ourselves, can we afford it? What impact does this have on our budget? And then resource allocation. Once we've decided that something is good for us, we decide to allocate resources there. And at all this time, we should never forget the concept of opportunity cost, meaning for any resource allocation, it means that resources has to be reduced from somewhere else. So it is a trade-off. There is always something that we have to forego for us to move the resources towards a new component. Then, of course, the outcomes research, where we look at the clinical outcomes, patient-reported outcomes. This collects data on patient perspectives regarding their health status, quality of life, and treatment satisfaction. I think now in the discussion in the quality of healthcare bill, these are one area that was being discussed a lot. It's not normally very easy because there's a lot of subjectiveness in it, but across board right now, it's agreed that patient-reported outcomes should be part of KPIs of any healthcare system. Then the comparative effectiveness research, because every one time there is 2, 3, 4, 5 technologies coming to the market at the same time. So you have to do some comparative research and say, so which one do I go for first? So if you're talking about Kenyatta National Hospital, there you have to ask yourself, do I build, the bridge across the road to avoid road traffic accidents, or do I expand my A&E department? That's a comparative effectiveness research, and we'll see how we do that. I think these ones will go back to them later. I wouldn't want to belabor a lot, but the concept here is the cost effectiveness analysis. That's where you want a big bang for your buck. Real world evidence is very key. This is the bloodline for HOR. Patient reported outcomes, as I said, very key. And of course, health technology assessment for government. So economic evaluation. So this is quite key. We quite have a number of ways that we do the economic evaluation, depending on what we are trying to check. So the easy one and the most easy to do is the cost minimization analysis. So if you have two technologies and they're giving you equivalent outcomes, then you just check which one is cheaper. I think any rational human being would do the same. If I'm getting the same outcome here, then which one is cheaper? Then you have the cost effectiveness analysis where it measures benefit in terms of natural units. And natural units here could be life year saved, it could be, millimeter mercury reduction. So the cost effectiveness analysis would examine cost of alternative approaches to achieving a specific health objective. And most of the time, this is a clinical indication. So I have two hypertensive medications. Which one do I go for? Depending on which one, for every reduction in millimeter mercury, how much extra am I supposed to pay? So it's relatively easy to communicate, but the problem with this is you cannot compare interventions across the health sector. So you can't use the cost effectiveness analysis to compare if you need to build a new cath lab within your facility, or should you put your money in, let's say, vaccination, because the outcomes is not the same, and that's why cost effectiveness fails in that area. Then you have the cost utility analysis. Cost utility analysis incorporates a utility into the effectiveness matrix, and this is where we go to the QALYs and DALYs, and we'll discuss them a little bit after this slide. So the cost utility analysis would use a non-financial common metric that would allow comparison across health sector. So here you can compare drugs versus technology. You can compare mortality heavy intervention, let's say road accidents, and morbidity heavy interventions, something like depression. That you can only do with the cost utility analysis because the metric is able to combine length, quality of life. So mortality, morbidity, you're able to do that. And we'll see how those two are calculated. Then there's the cost benefit analysis. Normally is considered to be the most comprehensive economic evaluation, but not very useful when it comes to healthcare because it measures benefits in monetary units. So it places a monetary value on inputs, that's the cost, and then you place a monetary value on the outcomes as well. Then you can easily compare projects across, the entire economy. Now, why it has lost its efficiency in the healthcare is because sometimes it's very difficult to put a monetary value to health outcomes. So it's very difficult to say how much is a 2 points reduction in HbA1c, let's say, in diabetes. So the cost benefit analysis would indicate intervention desirability independently of a comparison to alternatives. So the net benefit is you take all the total benefits and you subtract the total cost and you get a ratio of that. Then, of course, over and above, once you do any of those economic evaluations, then you do a sensitivity analysis, and this is where you expose it now to a number of assumptions and to see if your numbers would work well. So for the sake of our topic today, then I would work more on the cost utility, because that's the one that is universally accepted as a good economic evaluation when it comes to healthcare. So utility generally in economics is a measure of satisfaction. That's what we call utility. And so we try and find ways or a matrix or one indicator that we can use to combine a number of outcomes. So a QALY, which is a quality adjusted life years, is a combination of life expectancy, so the amount of life you have, and quality of life. So you integrate mortality and morbidity into one single measure that would express health status in terms of equivalence of well years. And it's measured on a scale of 0 to 1. So if you can see, the y-axis is health-related quality of life. So perfect health, we start at 1. So we always say that everyone is born with a certain stock of health, which we expect is a perfect health at the beginning. Then with time, of course, these would go down. So if you can look at the diagram which appears on the left from my side, is that the blue part is your life without the intervention. That is part A. So you live your life, of course, the health quality of life would go down till 0. So 0 is death, which is 0 quality of life. But if you are able to use intervention, a certain intervention, then you are able, let's say, to increase your quality of life, and at the same time increase your length of life. So if you are looking at the example that I've put there, the estimated survival, let's say, without treatment. So if you didn't take this treatment, your estimated survival is 10 years. And you live with the quality of life of around 0.7. Then that means your QALY without treatment is 7.0. So that's the number of years you live with that quality of life. Now, let's say if you don't take the treatment or you don't take the intervention, then you live, let's say, 5 years shorter and a bit of a lower quality of life of around 0.5. So that gives you a QALY of 2.5. So using this example, the QALY gained from taking this treatment or this intervention would be the QALYs you have with the treatment minus the QALYs you'd have without the treatment. So we would say QALY from this treatment, the QALY gain from this treatment is 4.5 QALY. I hope that is clear. So that's how you calculate the QALY. It's simply the number of years with the quality of life. Then you can check with or without treatment. So most of the time, the without treatment would most probably would be the comparator or standard of care. So if it's a new medication, you'd say with medication A, people would live on average this number of years, and their quality of life is this. Then if I bring a medication or an intervention that I say this is able to reduce mortality and it also improves quality of life, then we calculate how many years more would it give, and what would be the difference in terms of quality of life. Then you're able to calculate. Now, once you get the quality, like here we have the 4.5 quality, assuming, let's say, the cost of the new treatment is 18,000, let's say 18K. Then you'll go and divide 18K, divide 4.5 to show that if we take on this, if we accept this intervention, then we get 18 divided by 4.5, I think would be 4. So that would be 4,000 per quali. Okay, so 4,000 per quali. So you take the cost of the treatment and then divide by the gain. So the quali here is the utility, and say, okay, 4,000 per quali. Then as we go ahead, I will show you where we have thresholds, where we say, so what amount per quali makes sense, what is cost effective. We have thresholds for that. But I hope this gives a flavor of how that is done. And just to be sure that I'm still with you guys, I'll ask us to do a bit of a short calculation. Just take the screen again, the QR code, and do the calculation. So imagine a patient is living with glaucoma that impacts their quality of life. So without treatment, their quality of life is rated at 0.5, and they're expected to live for 4 more years. So for 4 years at a quality of life of 0.5. Now we have a novel new treatment that is available that claims to improve the patient's quality of life to 0.8. So the quality of life would improve from 0.5 to 0.8, but has no mortality benefit. So how many qualities does the patient gain from the treatment for those 4 years? I'll give us 2 minutes to do that. So I'm not able to see the questions on the chat or anything. So if there is anything, please, Lillian, you'll inform me.
Yes, that's it. And there are no questions so far.
Okay. So I hope guys are doing the math. The problem of showing the answer is that if anyone was of contrary opinion, would now feel intimidated to go with the class average. So if we have like some 30 seconds to go, then we'll move. But thank you so much for the ones who've responded. Okay, thank you so much. So yeah, true. The answer is 1.2, and this is how you get to that. So the quality of life without treatment is 0.5. Years lived without treatment is 4. The quality without treatment is 0.5 times 4, which is 2. Then you calculate now the quality with the treatment. So with the treatment is the quality of life is 0.8. The years of life doesn't change. So that gives you 3.2. So the quality gained from this glaucoma medication is 1.2 quality. As I said again, here we did not put the cost part. So this is just purely now the outcome side of the equation. So if you really want to do now cost effectiveness, is where now you'll have to divide these qualities with the amount or the extra amount. So if a drug A was 10K and now I introduce a drug B that is 20K, and you're comparing between the two, then even the prices you'll have to compare. You'll have to take price B and subtract price A. So thank you very much for that. So the other utility is the disability adjusted life years. So this is accepted as a measure of overall disease burden, and it's expressed in terms of years. The calculation is simple. The years, you have the years of life lost. So years of life loss is the difference between your life expectancy and now when you actually die because of a disease. Then you have the years you live with disability, and then the years lived with disability, you calculate that by multiplying that with the disability weight. Now there is their list for disability weights, where they've tried to put weights, certain weights to different types of disabilities, and I wouldn't go into a lot on how they calculate that. There's still a lot of debate on, how they get to those weights, but currently it's still our best mode of how we calculate this. So if you are to look at the diagram on my left side, so from birth to death, so assuming that whole arc was your expected life, then somewhere in between you develop a certain disability, you live with that disability, and then at some point you die because of the same. Then the orange part is what is now our DALI, which where we combine the years that you live with the disability. Always remember there is a disability weight, so it's not just the years, you have to multiply with the disability weight, because not all disabilities are the same. That's the gist of it. Then the years life lost, so what the difference between the life expectancy and what exactly the time you did die. So DALIs are a measure of something lost. So it's not like the qualis. The qualis you gain, but DALIs are not desired. It's something we want to reduce. Yeah, so a DALI is something you want to reduce because it's a measure of something lost. Then we have other utilities like health adjusted life expectancy. So this is the number of years a person is expected to live in good health, but those are rarely used. So DALI, as I said again, is the years life lost, years of life lost. So that is the difference between your life expectancy and the time you die. Then the years lived with disability times the disability weight. Of course, by now I think you knew this was coming. I know the qualis and dalis are always very confusing. So every once in a while you have to go back to them. But I think once you do your calculations once in a while, it's a good way to remember what they are. So for this particular one, a patient is diagnosed with diabetes at age 25, not managed very well. So at some point she develops a diabetic foot and undergoes a leg amputation at age 35. We want to assume here that leg amputation, let's give it a disability weight of 0.4. to note that this is not its exact disability weight, just for the sake of our calculation. So without one leg, this patient lives for 20 years and then dies at age of 55 due to complications of diabetes. Now, assuming this lady was living in Kenya and the life expectancy for a lady is around 70 years, let's scan and see if we can calculate the DALYs lost. I'll give a few minutes. In the meantime, as you're doing the calculations, if someone has a question on the same, you can always unmute and ask, or put it in the chat box, and Lillian will let me know.
So we have someone asking if you could please go back to the formula on DALY.
Yeah. Okay. I hope they've copied it, so that we put the question. Go back. There's no response so far. So if there's a point that anyone needs clarification in the question, please just let me know. I think it's quite important that we understand how all these come about, because then they are key in the whole HOR matrix. Sometimes they're a little bit more complex than this because as you know, patients don't read textbooks, so it's rarely this straightforward, that it's cut and paste. So you'll have one patient with multiple disabilities on different medications. So sometimes the calculations would be a little bit more tedious with a lot of assumptions. Good. So we're having 5 people have responded so far. Seven responses. Good. Thank you so much. So so 15 more seconds and then we'll move. Seems some people are revising their answers, which is a good thing. So good. Thank you so much for that. So yeah, you correctly mentioned a good number of you got 23, and that's actually the case. So the step one is you calculate the years of life lost. So the life expectancy is at 70. Our lady died at 55. So years life lost is 15. Then now you check the number of years she lived with the disability. The years lived with the disability is 20, and we had given the disability weight of 0.4. So that gives you 8 years. So if you are to add the two, the years life lost and the years lived with disability, you get to 23 years. We will come back to this number later on as we are trying to calculate something. So once you've done that analysis, we have what we call a cost effectiveness plan. In this cost effectiveness plan, if you look at your x-axis is your cost, then you have the y-axis, which is the incremental effectiveness, and the intersection there, that would be your comparator. So if you're looking at quadrant A, where the new intervention is more costly and less effective, so that one, I think that's a no-brainer. No one would even think about it. Then you have quadrant B, where the new intervention is more costly, but it's more effective. So this is where then you get a lot of challenge, because you're being expected to pay more, but at the same time, you are getting more value. So we will come back to that. The C, decreased cost, most effective. So this is also a no-brainer. If I'm going to get more value for less money, then you definitely invest in that. Then you have quadrant D, where it decreased cost, but less effective. So there is rarely good value there. So that is also a gray area. So if you are in B, we normally calculate an ISA, which is the incremental cost effectiveness ratio. So we calculate an ISA if the new intervention is more costly and more effective. And this is a ratio. So another ratio, a smaller ISA is better. And I've given the formula there on the left. So you look at your mean cost of the new intervention minus the cost of the comparator, which most of the time is the standard of care. Then you look at outcome B minus outcome A. So of course, looking at that ratio, a small ISA is always better. Sorry. So if the intervention is less costly and less effective, there's also a DISA, a decremental cost effectiveness ratio, which you're trying to measure savings per outcome lost, but in theory, we rarely use that. But the cost effectiveness, the quadrant B is where it's most important, where you have increased cost and most effective. Now, which ISA? Now, if you look at the green line is the willingness to pay threshold. This is where now we say, what can we afford? So something could be good value, but we cannot afford. And how do we calculate this? We have, these are some of the thresholds that I was able to pick somewhere, where you have a lower boundary and an upper boundary. So the USA, the Canada, you see they'll use the quali. So if your quali is below $100,000 per quali gained, then it is counted as a cost-effective intervention. If you look down at where we have the WHO, so that is the one that we use mostly for low middle income countries, where we rarely use a fixed number, and we plug it into your GDP per capita, meaning your level of richness, what makes sense. And there they say anything that is below 3 times your GDP per capita is cost effective. And what I mean by cost effective is it means it is quality for money. It's value for money. Okay, I think it would be very important to make it clear that cost effective does not mean cheap, and it does not mean affordable. And I think we'll discuss that a bit later. Actually, I would suggest that you put in the charts what are the differences between cost-effective, affordable, and cheap in the charts, and we will discuss that. So these are some of the thresholds, and I want us to do a small calculation using the DALI that we had talked about before here. These apply our GDP per capita in Kenya and see if a medication would have given her would be cost effective. So let me get to that. Yeah, and this is how we'll be doing this presentation. We are going sambamba with you guys, present together. So this is the same patient who we had an amputation at 35, complications for diabetes, and died at 55. And the total DALIs lost due to diabetes and amputation was 23 years. Okay. Now, considering the WHO ISA threshold of less than 3 times the GDP per capita, and if you were to take the Kenya GDP to be around 2,000 USD, so it's actually around 2,100 USD currently, but let's take 2,000 USD. Are we able to determine if a drug, if we got a drug that causes that is costing 1,000 USD, would that be cost effective? So I know these are a lot of numbers. Your first paragraph is actually just a repetition. So from there, don't even look at anything. Just look at DALI's 23. The rest, I was just it's the same thing we did previously. So if you have 23 years lost in terms of DALI, using a threshold of 3 times the GDP per capita, of which here the GDP per capita is 2,000 USD. So don't convert even to Kenya shillings. Just keep it as USD. And let's see what we think about this intervention. If there's any part that is not clear, please ask. If you need a clarification on anything, please ask.
No questions so far on the chat.
Okay. And Lucy, you can tell me how much time I have so that I know how to manage the rest of the slides.
You can have 15 more minutes and then leave the rest
Okay.
for question and answer.
All right. Thank you. Thank you very much for that. The rest are calculating. So 15 more seconds, then we'll move to Okay, thank you guys. So this is the answer. So what would be the threshold here? The GDP per capita is 2,000 USD. The threshold is 3 times of that. That makes 6,000 USD. Then calculate the cost per daily averted. So the cost of the drug is 1,000 USD. We're only able to avert 23 years. So that would give you something approximate 43.48 USD. So you compare the two and you see that it is cost effective. So as I said again, the cost effectiveness does not mean cheap or affordable. And I hope someone is writing on the chat the difference between those three, even as we discuss. So that's the health economics part, which is sometimes the harder part because it takes a lot of mathematics on it. The outcomes part is more qualitative, equally as important, but also very difficult to pick the data. So the outcomes, of course, they are economic, they are clinical, and then we have the humanistic ones. So the economic one is the total cost we need to achieve a certain outcome. Then the clinical is, of course, what we deal with on a day-to-day basis when it comes to morbidity and mortality. Then you have these humanistic ones, which are death, disease, disability, discomfort, dissatisfaction. And there is quite a complex and elaborate way as to how they give weight to all this. So the first two are quite objective. When you're dead or you're having disease, then the rest is subjective. So part of disability, assuming we are discussing about, let's say, depression, the disability of it is quite subjective. It's not something you can measure. Only the patient can tell you that, okay, for 2 days in a week, I'm not able to do my work or something of that sort. So we have those outcomes. Then we have surrogate outcomes. When it comes to surrogate outcomes, so these are outcomes that we can use on or for the other outcomes. So we have the perfect ones, where the outcomes accurately and consistently predict the clinical outcomes and have a direct causal relationship. Example is the relationship between hypertension and stroke. So the prevention here is lowering systolic and diastolic blood pressure, and the clinical outcome here would be reduction in stroke incidence. Reason being, high blood pressure is directly linked to increased risk of stroke, and effectively lowering blood pressure is well documented to show a reduction in stroke risk. So the two can be used as surrogate outcomes for each other. So if you don't have clinical outcomes for stroke reduction, you can check hypertension reductions and use that as a perfect surrogate. Then you have acceptable surrogate, like these are ones that are reasonably good predictors of clinical outcomes, but may have limitations or have some bit of indirect association. An example is tumor size reduction in cancer treatment. So the surrogate here would be reduction in tumor size or progression-free survival. The clinical outcomes will be increase in overall survival or quality of life. And the reason here would be, the reason why it's just an acceptable surrogate and not a perfect one is that despite the fact that reducing tumor size is generally beneficial and correlates with better outcomes, it doesn't always translate to longer survival or improved quality of life in all cancers. So we use it as an acceptable. Then you have the unacceptable ones. So these are the ones that do not reliably predict clinical outcomes. Where do we get this data? This data come from all sorts of areas. So nowadays it's actually more robust, where we have wearables, consumer data, mortality data, social media data, pharmacy data, hospital claims data from insurance. And I wouldn't go too much into the details of the difference between the real world data, the insights, and the evidence. But all these elements together help bridge the gap between the clinical trial environment, so what we get in terms of studies, and actual clinical practice. And this provides a more comprehensive understanding of the intervention and their impacts. So real world evidence, when it comes to HOR, then real world evidence is always key. So these are some of the questions that you want to ask when you're selecting which outcomes data you want to use for your study. What level of evidence is necessary to address the question you're trying to answer? What outcome measures are relevant in that particular instance? As you said, you can use the outcomes itself or the surrogate outcomes. What outcome data can be feasibly collected and analyzed? So that is always key, because garbage in, garbage out. If you can't collect it, then any analysis you do would not be correct. The other question is, normally, should the outcomes be discounted? So that is adjusting for future value for present. And rule of thumb is, normally, if any outcome, if the benefits will be seen more than 1 year in future, then you should be doing some discounting. And then the question is, how do you present that? These are some of the areas that HOR is of use. So in the pharmaceutical department, healthcare providers, government and health agencies, and insurance companies. As you can see, there's a bit of quite traction towards this area in sub-Saharan Africa. This is the number of publications you can see from the year 2000, where we had less than 50, to now where we are getting around 340. So this shows there's a lot of studies being done, and these are key because, as we said, any health technology assessment kind of endeavor can only work if you have inputs from HEOR studies. In the absence of these studies, then you cannot do any health technology assessment. You can only accept the data that you are given with whoever is presenting the technology at that moment. So the relevance is actually on the rise, and it shows quite some bit of potential. As you can see, these are a number of the countries that are moving towards that, and with the different scopes. And I wouldn't go into too much details about that. But as you know, in Kenya, as part of our new dispensation, there will be a component of health technology assessment to inform health technologies going forward, and I'll show you that before. So I tried to check the situation in Kenya, and you can see this was in 2015. And when it comes to, and this I picked from the WHO website, so you can see from governance to purpose, process, everything was nearly zero. So there's no national HT organization. There was no legislative requirement at that time. So this has changed recently. So we have something in the pipelines on that. You can see on the right the KEMSA procurement model going through the whole of it, and you cannot see anywhere where is informed with the data. So this is some of this is the route we are taking as a country, which is quite a good sign. As you can see, on the right, these are the new acts which are now. I think a number of them have already been passed now. So you can see that there will be a benefits package and tariffs advisory panel that will be based within a local public university and appointed by the cabinet secretary. And you can see part of their mandate will be to review and update existing tariffs in accordance with the applicable health technology assessment. So this is an area that will be quite useful going forward, because the new social health insurance fund will need a scientific basis on what they cover and why they cover and for how much they cover that. So I think this would be my last slide, which is quite important. I picked it from a book. I couldn't remember which book that was. I've been trying to find it. But it pretty much says that it's no longer enough for clinicians to know only the clinical effectiveness of interventions. They must also understand the cost effectiveness to ensure the best use of limited resource. So this is what it pretty much means. If I was to translate it, is that cost is equally an important an outcome than just the clinical effectiveness. Uh, and I think that would be my last slide. Thank you so much. I would open it up more for discussions now. Back to you, Lucy.
Thank you, Doc, for that enlightening discussion. It was very informative, especially the calculations, and I liked how interacting it was at top as well. So there are no questions so far, but if anyone has any questions, then please feel free to raise your hand and we'll be able to unmute you. Or if you can't do that, then type it on the chat. Maybe I can ask just one question. How can we, let me start by asking, are there any challenges faced in the implementation of health economics and outcomes research in health products procurement?
Yeah, so for any healthcare procurement, let me just stop sharing first. So when it comes to health products procurement, the question of cost effectiveness is quite key. So you're asking yourself, where do I put my money to and get maximum benefit? Because at any one point, I'll give an example. If let's say we are talking about diabetes, there's 1,001 medications on that, and you have limited resources. So the question is, which ones do you cover and which ones do you not cover? Now, the ones that you don't cover, it doesn't mean they're not important. It just means you must get an objective way of saying which ones make more sense. So this is it's a bit of a new stance on our side. It becomes more important, especially when in markets where reimbursement is very key. So like for us, when now we are moving to UHC, and the vehicle we've decided to take us through that is the social health insurance fund. So the chief has to decide. Give a good example. Right now, I think from the benefits package they showed, let's say they've said they'll pay 11,000 for a cesarean section. So the question is, of course, 11,000 will not be enough if that cesarean section is being done by a gynecologist, a specialist. So most probably it's assumed that it's done by lower cadres. So the question here is there a difference in outcomes if a cesarean section is done by a gynecologist compared to if it's done by a medical officer? As clinicians, we would say most probably there is. There is more quality if it's done by the gynecologist. But here the importance is not that it is more beneficial. The question is the difference worth the cost? Is the difference in outcomes if a CS was done by a gynecologist compared to if it was done by a medical officer? Does it make sense to pay the difference? So it's the difference in cost here that would matter. Otherwise, we would just say everyone go to a gynecologist. Another good example I would want to give maybe is let's say in the UK. In the UK, you can't walk directly to to a specialist. You go through your primary care physician. Okay, so that's how countries do the calculations and say, okay, a good number of the conditions that you go to can be managed by your primary care physician. So why would the NHS pay a specialist for that? So they will only pay if you've gone through the process and the primary care physician has said, this is too much for me. I would want to refer you. Then they would pay that. So every country has its ways to do it. It's not easy, but you start somewhere as you build.
Okay, thank you so much for that.
So I had asked about the cost effectiveness, affordability, and cheap. So cost effectiveness, something that is cost effective, it just means that it's good value for money. So it means if you had the money, take it. It's good value for your money. Affordability speaks to your budget. Something could be cost effective but not affordable based on your budget. So affordability speaks to ability for you to buy that. And of course, cheap just means the cost is low. So that's the difference.
All right, thank you. I'd actually post that to the rest so that they can remember it as well. So there's a question. Someone, Lois, says, can we calculate cost effectiveness of care at the initial stage? In the presentation, the calculation has been done based on the morbidity and mortality, meaning this was done after many years of care and even death.
Okay, thank you so much, Lois. So the cost effectiveness can be done at any part, any stage. What is important here is what outcomes, what you'd use as the outcome input. So let's say you're saying about HbA1c reduction. So this could be early on. You see, like the lady we calculated had been mismanaged and ended up with an amputation. So that was a bit later in the game. But at the beginning, you can say drug A reduces your HbA1c by 1, the other one reduces by 1.6. What is the difference in their cost? And say, okay, for every 1% reduction in HbA1c, I'm paying this amount of money. Then now you balance it out with your thresholds and say, is this cost effective? Now, another thing that I would want to mention here is every time you do a cost effective, so as we said, the HOR feeds this data into the health technology assessment. Now, the health technology assessment team, at the end of it all, will always do a budget impact analysis. The budget impact analysis is what now tells you about affordability. So over and above something be cost effective, then you put it and say, within our budget, can we afford it? If not, then it's not covered. If you can, then you do. I hope I answered your question, Lois.
She has not gotten back, but I'm seeing we have 2 minutes. So I know it's a Friday evening, so I wouldn't want to take. Okay, maybe you can take Mohammed's question.
Mohammed Ali, go ahead.
Mohammed, you're good to go. You can unmute.
We'll be having challenges with this connectivity. Mohammed Ali, if you can't reach, then you can just type.
So, Nemera, the slides will be shared after the session. Just to let you know, because I've seen you've been quiet. Can you touch the slides? Yes, they'll be shared to you via email. So there's a question, please comment on the effectiveness of economic models in the calculation of CUA results, more so in the African context.
Thank you, Katia. So, cost utility analysis in the African context. Now, what you'd realize is that most of these calculations would require a lot of local data. And that's why there was a slide about real world evidence and insight and all that. So I think that is where we are handicapped. It's not that the effectiveness is low. The effectiveness will be as good as anywhere else. But the inputs is where now we would have a challenge. A good example is even when we are talking about the disability weight. Okay, the disability weights actually how they get a number of them. There are several ways they do it, but one of them is through even asking people, what would you, how would you weight, living 10 years without hearing? Okay, now these are also very geographic sensitive, meaning a disabled person in Canada might not weigh his disability the same as someone who lives, let's say, in Kenya. Because for someone in Kenya, his disability might have more impact on his quality of life than somebody else there, because the society there has kind of adopted and created a scenario where they can manage better. So if I'm using a disability weight that was done in the Netherlands for a cost utility analysis in Kenya, I think you can understand where the challenge here would be. And the weight is very important. And the weight is based on, it's not based on anything objective that you can measure. It's based on patient feedback on how they would, or the population feedback on how they would weigh a certain level of disability. So to answer your question, Gatia, I think the effectiveness would be if we get the data. And I think right now, as this field is growing, as you've seen, a number of people are really doing a good number of studies. I think with the time we will get somewhere. We might actually even develop our own utility matrix and not use the qualis and dalis as any other countries you've seen. If you look at the ISA threshold I was showing, even Australia, they're using a different matrix.
Okay, thank you for that, Doc. I believe that answered your question, Gatia. So Mohammed got back and asked, how can you calculate the cost effectiveness of a vaccine like polio?
Thank you, Mohammed. So as I said, here you have to look at the outcome. Okay, so let's say you look at the patients or the people who've been given the vaccine, and or even look at the people who did not get the vaccine. So use the DALI, the disease adjusted life years, and you see how much the lack of vaccine cost them in terms of disability and life years lost. So you had these people, they would have lived for 70 years, they lived to 45. And not just living shorter, let's say they were 45, from 25, they were disabled. So you're able to calculate that and say, that's my outcome. Okay. Then you say, okay, to prevent such an outcome, how much do I need to invest in the vaccine area? Okay, you calculate that amount. And then you say, for every $1 I invest in the polio vaccine, I'm able to add 3 years to my people's life and some level of improved quality of life. So that's how you approach it in a very simple way. It's rarely that direct. As I said, there are so many other factors that would play in, including discounting, because if you miss a polio vaccine today, you see the effect 7-8 years down the line. But on a simplified way, that's how you do it. And let's say you wanted to compare the cost effectiveness of a vaccine compared to, let's say, building a pediatric hospital. So that's how you do. So you'll say, for every $1 I spend in a vaccine, this is the amount of dollars I'm able to avert. For $1 I spend in building a pediatric hospital, this is the amount of dollars I'm able to avert. Then you check the two and say, okay, which one is cost effective than the other. So you can do it for one intervention. You can do it as a comparator. So you're comparing one thing to another.
All right, thank you, Doc. I believe that answered the question really well. So before we wrap up, I'm seeing we have 5-6 minutes past time. Before we wrap up, I'd like to just make one announcement. That we have an opportunity for you to deepen your knowledge and skills in the area of health procurement. We have a supply chain course that is coming up. It's scheduled to start in July 6th, and it's meant to equip you with the latest insights and practical tools to make informed decisions on procurement of health products. So the course runs for 3 months. It's to take place once a week on Saturday mornings, and it's 300 USD. And you can visit our LinkedIn or even our contact. I think I'll just share the contact in case you're interested in that course. So that's an opportunity for you to explore the field of supply chain procurement. And I think with that, I don't want to take any more of your time. I'd like to thank everyone for participating. There was active participation, even in the chat, in the polls that Doc has been able to launch. And a special thank you to Dr. Ahmed for the very informative session that we had. And I guess with that, I can wish you all a lovely weekend.
Thank you.
Okay. Thank you, everyone.